Thank you very much. I've actually split this talk into two because I want to talk about transmission. We can't have a day on lockdowns without talking about transmission. Sorry, can we get the slides? Oh, brilliant. Okay. So I'm going to talk first about transmission and then go on to talk about how we've overdiagnosed COVID. Now, the truth is that we don't fully understand the transmission of this disease, and we don't fully understand the transmission of other respiratory viruses either. So it's important we talk about that first. I'm going to talk about the lack of evidence for asymptomatic transmission, and then the importance of hospital spread. Now, all of the modelling has been done on the basis that SARS-CoV-2 spreads like measles. Measles spreads person to person. There's a continuous chain of transmission that happens throughout the year, and somebody who's infected will go into an environment, home or school, where there are susceptible people who will then catch it, and you will have more secondary cases than that primary case. An alternative model would be influenza. Now, we don't fully understand influenza. It does spread person to person. There is evidence of that, but it's not the whole story, because in influenza, it disappears over the summer, and then it comes back in winter as a surge. And those surges happen at the same latitudes across the world, simultaneously with the same genetic profile. And that can't be explained by person-to-person transmission, and it happened well before we had international travel the way we do now. And with influenza, the primary case does not result in a huge number of secondary cases in the household the way it does with measles. We know it's spread through aerosols. And in fact, in winter, in indoor environments, after an hour, you will have had an infective dose of influenza if you're in a public indoor environment. So it's not about the environment, it's about the susceptibility of the person who's in that environment. And what we've also seen for hundreds of years is that people who are out at sea with no contact with anyone else can have outbreaks of influenza. So what's the evidence for COVID? Well, we have seen these surges, which cannot be entirely accounted for by behavioral change. With the measles model, when you reduce restrictions, there should be a rebound in infections. And in the summer in the UK, we didn't see that. With the V celebrations, the packed beaches, the marches, there was no rebound. And more recently in the USA, we had Biden calling the governors of Texas and Mississippi's Neanderthals when they released all their restrictions, and there was no negative consequence, and the trajectory continued as it did for all the states that had strict restrictions throughout. COVID has low household transmission, like influenza. Only about 8 to 15% of contacts end up catching it. Like influenza, we had an Argentinian fishing vessel where everybody tested negative before they set sail, and 35 days later, there was an outbreak of COVID. Like influenza, COVID spreads through aerosols. We've seen quarantine hotels where patients have caught the same genetic virus as somebody elsewhere in the hotel that they have never met. We've seen it filling the air filtration systems of hospitals. And not with SARS-CoV-2, but with other coronaviruses, people have taken air and managed to grow virus in cell culture 10 miles away from where there were infected farm animals. Now, Canada have been quite open with their data. They've shared data on test and tracing, which shows that they only found a source of infection in half of their patients. And that was true during their winter peak, but it was actually also true recently when case numbers have not been very high. And it's been true despite lockdowns. So lockdowns do reduce human contact. And what you can see in this top graph is data from emergency attendances in the top graph is for gastroenteritis. So we have the beginning of 2020 up until now. And the blue line shows the global mobility data. So as people locked down and as mobility increased, the correlation with gastroenteritis cases is really, really tight. Now, you wouldn't expect that to be an epidemic-type spread, but you can see that it did have an impact on that disease up until recently. COVID COVID's in the bottom graph, and you see that as we increased mobility in the summer, there was no rebound. We didn't have much change in mobility and then saw a rebound. So we don't have the relationship in the same way. Why are we told that behavior is what's driving spread? The evidence does not support that, and this measles model has failed. Now, is there anything else we could learn from influenza? Well, I think there might be. I think we need to look back to 1957. There was a novel flu virus, and there was huge concern because it was believed that everybody was going to be susceptible. And then they had a bad winter that year. At the end of it, they tested people to see who had had an infection, and 8% of the population had antibodies. It then went away for the summer. And then it came back as a variant the following winter, and another 7% developed antibodies, and so on. Not every single year, there's some years it missed out, but it was 11 seasons before it was done. So was it a coincidence that in May 2020, 7% of us had antibodies to COVID, or is that actually exactly what we should have expected based on influenza? Now, some people who avoided that first pass and weren't susceptible then seem to have become susceptible later. And it seems to me that you can put a hypothesis that this susceptibility will stretch over years. And it's quite unreasonable to take a decade's worth of susceptibility and assume it's all going to come at once, but that is what was done. Now, I think we're all familiar with this assertion from the government that 1 in 3 of us had no symptoms but were passing it on. And there really is no evidence to support that. Healthy people can and have tested positive. They could have been immune, it could have been a testing error. And evidence of positivity is not evidence of spreading a disease. So these studies that have been done, which show a percentage of people have no symptoms, have shown really different figures. Some studies showed 4% had no symptoms, and it's gone right up to 76%. Now, a range that big makes no sense. If you were measuring a symptom like a cough, you'd expect a constant percentage. What you're actually seeing there is not a function of the disease, it's a function of the testing. The more tests you do, the more asymptomatic positives you find. So where's the evidence of asymptomatic spread? Well, what people tend to reference are modeling studies. Now, what these modeling studies do is they make an assumption that asymptomatic spread occurs. They then do lots of complicated mathematics and make beautiful graphs which show the effect that that would have on an epidemic, and they conclude that it's really important. But the whole thing is a fairy tale based on that initial assumption that it occurs. Where's the real-world evidence that it occurs? So there are reports in the literature of it having occurred. Now, a lot of these reports are of people who have tested positive with no symptoms, having been in contact with someone else who tested positive with no symptoms. And that is being described as the transmission of a disease. There are a couple of situations where people had symptoms. There was a mum with a runny nose for a day. There was a baby with a cough. But there are no cases of a severe acute respiratory syndrome or a pneumonia or somebody needing medical care because they caught it from somebody who had no symptoms. Let's just talk briefly about hospital transmission. This graph shows patients in English hospitals across the winter. In red, you see patients with COVID. In black, no COVID. And in green, here are the empty beds. Now, the empty beds were pretty constant. So were these non-COVID patients kindly clearing the way to make room for the COVID patients? Well, no. And SAGE have included in their report an estimate that in spring 2020, there could have been 40% transmission through hospitals. And this is what we saw with SARS-1 and with MERS. So focusing on the community, on pubs and on schools, is detracting from this. And this is really important. We could do something about this. NHS has been below capacity throughout, but ITU capacity was exceeded in spring and in winter. And it does seem that COVID produces higher morbidity. So people are more sick with COVID than they are with respiratory viruses from previous winters. But it's worth bearing in mind that the UK has less than half the ITU capacity per head of the USA and Germany. So we could be acting on this. We could be increasing our ITU capacity. We could be sorting out air filtering in hospitals, putting UVC into the filtering systems. So overall, we do not fully understand transmission of respiratory viruses, and we need some humility about that. Policy's been based on assumptions around transmission that the evidence does not support, and we could be acting now to improve ventilation and ITU capacity and stop pretending that lockdowns can affect a virus that is spread through the air. Okay, so I want to talk about how we have overdiagnosed COVID. COVID has been overdiagnosed because of bad diagnosis. We've had a poor case definition, which has resulted in people who are healthy being called cases. There have been errors in the test results themselves, which have inflated the figures, and both of these have impacted on the mortality figures, exaggerating the numbers who died. We define a disease as a collection of symptoms diagnosed by a doctor, and that doctor may use diagnostic tests to help confirm their suspicion. But that whole logic was turned on its head with COVID. COVID seems to be the result, a SARS-CoV-2 positive test result became the definition of COVID, the disease. And when you define a disease like that, what happens is a number of symptoms associated with that disease grows and grows and grows, and then you can include people who have no symptoms at all. And calling people who never develop symptoms a case of a disease totally undermines the meaning of the word case. So there are 4 situations where you could have a positive test but no symptoms. You could be in the pre-symptomatic phase of the disease. So for a couple of days, people who are going to develop symptoms can be positive and infectious, but they haven't yet developed symptoms. But you may just have breathed in contaminated air, and the air could have virus in it. But the test we do is so sensitive that that will be enough to give you a positive result, even if the virus never enters a cell. You could have a situation where the virus does enter cells, and your immune system deals with it, and you would never know you were infected, and you remain asymptomatic, but you test positive. And finally, there is no perfect test. Tests produce faulty results all the time at a low level, but there will be people who had a test error who had no symptoms. And including all of these asymptomatic positives as cases has inflated the numbers. Now, testing itself can fail. Every test involves a compromise. You have to choose, do I want to find every possible case, or do I only want to find the definite cases? And at the beginning of an epidemic, when cases are growing, overdiagnosing a few people is acceptable. But at peak deaths, you have to change strategy. You change strategy. Instead of focusing on the individual, you look at the population. You want to start diagnosing definite outbreaks. Instead of trying to diagnose every possible case, you want to find the definite cases, and you have to change your laboratory strategy. So you may have heard people talk about restaurants and say that there are 3 things restaurants can do, but they can only do 2 of them well. You can have fast food, cheap food, or high-quality food. Well, it's the same with laboratories, but the 3 things are high volume of tests, high speed of tests, or quality test results. And you choose 2. We chose volume and speed. And actually, those are good ones to choose at the beginning of an epidemic, but we haven't changed our strategy, and we have compromised throughout on quality, which has resulted in unreliable test results. Somebody who's infected will release up to 100,000 virus particles every minute into the air. They're about the size, the aerosols are about the size of smoke particles. If they fill the air, and waving a test swab through that air could be enough to have a positive test result. In fact, in a 5 microliter sample that gets tested from a patient, you need 5,000 particles of virus to represent a patient who's capable of infecting another patient. And we know that based on repeated experiments done in different laboratories, where they have shown that's what's needed in order to actually get virus that can grow in a cell. We also know it because the ONS, when they do their random sampling of the population, have shown that that's the figure that shows people who transmit it in their households. People with fewer virus particles than that don't transmit. PCR testing has been set up to detect 4 virus particles. So just to make that clear, you will be called positive when you have got 1,000 times fewer particles in that sample than is needed to be an infectious patient. And the quality assessment of the laboratories has been set up so that any laboratory that does not call a sample with 4 virus particles in it a positive would fail. So the consequence of that is that low levels of bystander virus and immune people will both be called positive tests results and then cases when they have no evidence that they are a risk to others. So what are we testing for? If we're not trying to find out who's sick, and we're not trying to find out who is infectious, if in a very upside-down world, you were trying to get the highest number of positive test results, the largest number of cases, admissions, and deaths, I'm not sure you'd go about it any differently. Now, this risk of overdiagnosis is well understood. This is Christian Drosten. He is the German equivalent of Fauci, and he designed the SARS-CoV-2 PCR test. This is what he had to say about the MERS epidemic in Saudi Arabia. The PCR method is so sensitive that it can detect a single genetic molecule of this virus. If, for example, such a pathogen flips over the nasal mucosa membrane of a nurse for a day without her becoming ill or noticing anything, then it is suddenly a MERS case, where previously terminally ill were reported. Now suddenly mild cases and people who are actually very healthy are included in the reporting statistics. This could also explain the explosion in the number of cases in Saudi Arabia, and in addition, the local media boiled the matter up incredibly high. So apart from the issue of exaggerating the significance of minimal virus, we have an additional problem of test errors and false positives. And this was noticed very early on by clinicians. James Barnacle's team at Imperial did an audit of the patients in their hospital who were labelled as COVID patients. And by the 3rd week of May 2020, only 2 to 3% of them had acute COVID. Those are the red ones. There was a handful that had complications, but the rest were incidental diagnoses. They were in hospital for another reason. We can also check the test results. So back in May 2020, React were calibrating the laboratory results ready for their study of random sampling of the population. And they found that 57% of the results from the laboratories they were planning to use were false positive. In the summer in Swansea, admittedly when there wasn't a lot of real COVID around, they found 87% of their positive results were false positives. And a study in Spain, where they checked using antibody testing, found that even the patients in ITU, who were described as COVID patients, 53% of them never developed antibodies. They were false positives. So there's a variety of causes of false positives, but the key ones are post-infectious positives and ones caused by cross-contamination. Somebody who's had COVID can continue to release viral debris for up to 90 days afterwards. They're not infectious anymore. But they could turn up at a hospital, be tested, and be called positive in a case, even if they're in hospital for another reason. And should they die, they'd be labelled as a COVID death. Cross-contamination happens when a negative sample ends up with virus in it from somewhere else. And this PCR testing is incredibly difficult to do. Highly qualified experts struggle with it because it involves massive amplification, billions of times. So the sample you start with is amplified so much. And back in spring 2020, the CDC had a problem with 33% false positives. And what they attributed it to in the end was a beaker that had been washed and was on the side 7 foot away from a negative pressure hood where the samples were. And that was causing the cross-contamination. So you can see what a sensitive technique this is and how very, very easy it is to have that problem. And the BBC Panorama programme did an expose of the lighthouse lamps in the UK, which showed a massive risk of cross-contamination compared with this. Because when you take a very sensitive laboratory technique and try to do it at scale, that is a predictable consequence. And yet we have expanded this laboratory capacity. We have just opened a new laboratory in Leamington Spa, which is planning to test through the winter for influenza as well as for COVID. Now, your false positive rate will vary by lab, and day to day. It can vary by season if there's cross-reactivity with a seasonal virus, and it will be worse when there are lots of genuine cases around because of cross-contamination. So if you want to understand your test results, you need to know your false positive rate. You need to calculate it repeatedly over time for each laboratory. Lord Bethell is a parliamentary undersecretary to the Department of Health and Social Care, and he's responsible for COVID testing. And he admitted back in October 2020 that these tests were not being done. Nobody knew the false positive rate. He later claimed that it was around 0.7%. Now that sounds low, but it's 0.7% of tests done. And when you're doing 1.5 million tests a day, that's over 10,000 false positives every day. And over the course of the epidemic, it would correspond to 750,000 false positive test results. And that excludes problems of cross-contamination and diagnosing bystander virus. Can we measure this overdiagnosis? Well, I think we can. There's another way of measuring the trajectory of this pandemic. So this graph is from REACT, and it shows patients who had positive antibodies for COVID. There were 10,940 of them, representative across the country. And then they asked these patients when they had their symptoms. And what you can see is that there was COVID around in the winter before this sudden surge at the end of February, making the first wave. This line is 0. It dropped to 0 in July last year. We then had the second wave and a winter surge peaking lower than that first wave. So I think this is a realistic trajectory of the pandemic. And it's an excellent predictor of total mortality. This top graph here in the black line is the total mortality figure, with the baseline being this dotted line beneath. And you can see that the gradient is the same, the peaks are the same. So this does seem to match. When you look at PCR positive deaths, which is this red line here, it fitted well in the spring, but the second wave has massively exaggerated the number of deaths compared with excess mortality. If we look at PCR hospital admissions, these orange ones at the top, you can see that, again, this second wave is much, much higher than the symptomatic cases. And in fact, we have to ignore this hashed level because we didn't have data after it, but just this early part of the second wave, there were 43% more symptomatic people than in the first waves. The excess deaths were about similar, but there were 120% more people diagnosed with a PCR in hospital and 88% more PCR positive deaths. So this has impacted the death data. Many people have sadly died of COVID, mostly near the end of their life, but some people who would have had many lives ahead of them. But the death data has been distorted. Now, people think death data must surely be the most reliable, but the diagnosis of death is an art. It's based on the balance of probabilities and the information that you know at the time, and a false positive test result can totally disrupt that. Added to it, any doctor who knows that their patient has already been listed by government as a COVID death would find it hard not to comply on the death certificate. How do you prove it didn't contribute this disease with so many symptoms? I think we can all agree that measuring death within 28 days of a positive test is a flawed measure. If we decided to measure deaths after vaccination in the same way, it would be totally unacceptable. So understanding the excess death takes a bit of context. And this graph shows deaths for different years per 100,000 people in the population. So it's not adjusted for age, but it is adjusted for the size of the population. And you can see the light blue line of 2020 here and 2021 in purple. The magnitude of this excess death curve is not extraordinary. What's most odd is the timing of the 2020 curve. But we have had previous years with similar amounts of death. So proof of overdiagnosis can also be seen because of a lack of deaths from other causes. Now this graph shows in red COVID deaths and in orange non-COVID deaths. And where the orange bars are below the 0, it's deaths that we would have expected from non-COVID causes that didn't happen. And in the second wave, as COVID deaths increased, these deaths from other causes also didn't happen. And as the COVID deaths decreased, they recovered. We've never aggressively tested for a respiratory virus before. But there was a study in Spain where they looked at elderly people who died of all causes and tested them after death. And they found 47% of them had a respiratory virus on board after death, only 7% of whom were diagnosed before death. So respiratory viruses appear to be common bystanders at death. The difference with COVID is that it has a very distinctive clinical presentation, and we have tested extensively, so it's very likely to be diagnosed. But had we tested like this for other respiratory viruses in the past, we may have found it was comparable. Now, in spring 2020, there were excess non-COVID deaths as well. The ONS estimated it at 15%. And some people have claimed these were under-diagnosed COVID deaths. Now, I think we have to remember that in spring 2020, healthcare was not being accessed normally. This is emergency department attendances, which halved in the lockdown. There was understaffing in care homes, hospitals, ambulances, when people had to have 14 days at home if they were sick. ITU and hospital beds were emptied. People were fearful that their colleagues would need them. There were blanket do-not resuscitation orders placed on the old and on people with learning difficulties. Ambulance staff were given lists by GPs of people not to take to hospital under any circumstances. Now, all of those things will have impacted mortality, so it's quite wrong to claim that all excess deaths must be COVID deaths. So just to conclude, rather than measuring infectious cases or sick people, our whole strategy around testing appears designed to have maximized positive test results. And by including asymptomatic positives as cases and ignoring the test errors, we've exaggerated the case numbers. This has fed through to exaggerated death numbers, and we know this because we have got missing non-COVID deaths in the data.